Yeah, for giving me this opportunity to share my learnings and with the pulmonologists and all of you. So here I begin my session. So before I begin, I would like to ask all of you a question. I believe today is the 10th session of ECHO. So I want to ask this to all of you that all of you are practicing pulmonologists. So do you refer patients for pulmonary rehab?
Participants, you can post your answers in the chat box. So yes, ma'am, we are getting responses saying yes.
Okay, that's good. And so when would be a time to refer the patient for rehab, according to you? When would it be a good time? Okay, COPD. ILD, yes. At the time of admission of serious respiratory illness. Okay. Difficulty in carrying out activities of daily living. All chronic respiratory diseases. Yeah. Persistent symptom and limitation of activity. Yes. Okay. So most of you would be sending the patients for rehab. However, many times timing of rehab is very important in these patients, especially when we are talking about palliative care here, and we are talking about patients who may or may not be living at the end of 1 year. So that is typically when they say you should refer the patients for palliative care. However, referral to the patients for pulmonary rehab comes much before, maybe at the time of diagnosis, or at the time when they have difficulty in carrying out their leisure activities. So we'll come to that. And one of the participants said that when there is admission and serious respiratory illness. So we'll come to that during my presentation. Okay. So what is pulmonary rehab all about? Most of you must be aware that pulmonary rehab is a multidisciplinary approach. It is basically individualized according to the condition of the patient, and it gives attention on physical, social, mental, vocational, and economic function of the patient. Here, though I have just mentioned these two because these are primary needs of the patient that we need to cater. But along with that, when we see a person as a whole, we cater to all these things.
Sorry for the interruption,
Now,
Dr. Ankita.
in a recent publication by BTS, this terminology was coined that palliative care and pulmonary rehab are two sides of the same coin, because palliative care and pulmonary rehab both
Dr. Ankita, can
are
you hear me?
directed towards improving the quality of life of the patients with chronic respiratory diseases. With a goal of managing symptoms, helping them to manage their day-to-day activities with symptom, improving the independence, or trying to optimize their function, may it be daily activities, work, or leisure, thereby improving the quality of life. A holistic and a person-centered approach is there. That is individual approach depending on the profession the patient is in. We target the therapy accordingly. and the needs, specific needs of the patients. Um, we not only
Dr. Ankita,
not
can you hear
only
me?
deal with the patient, but the family and friends of the patients or the caregivers are also involved in the therapy, so that we can improve the adherence of the patients. And the of course the access is based on the needs. So basically, we assess the patient, and accordingly we tell them to we plan out a program such that we can help them to gain maximum independence in their day-to-day activities with whatever is needed. So,
Ma'am, can you hear
you
me,
guys
ma'am?
must be, all of you must be aware about this vicious cycle of chronic pulmonary diseases, the cycle of immobility, which is a negative spiral. So, immobility leads to difficulty in doing day-to-day activities, thereby decreasing the exercise capacity, causing physical deconditioning, and increased breathlessness. Now, what pulmonary rehab does over here is it tries to reverse this cycle of immobility to the vicious cycle, to the precious cycle of mobility, we call it. So, how does it help? It helps to uh, give you strategies to decrease your breathlessness, thereby improving your ability to the patient's ability to do day-to-day activities. End result is increased exercise capacity and physical reconditioning, thereby causing decreased breathlessness for the same amount of activity.
Ma'am,
What
can you hear me?
indications? Few indications we've heard: any chronic respiratory disease with any diagnosis, or like COPD, ILD, connective tissue related ILD, or maybe lung cancer or cancer with metastasis, or also pneumonia, cryptogenic pneumonia, lot of things to name here. However, once the patient is admitted or not admitted or at diagnosis, we see that uh, some symptoms which are not proportionate to the amount of activity they do. Like, for example, if they do a 6-minute walk test, or if they do any kind of simple activity like walking about, say, 50 steps, or getting up from one room to the other, we see that the parameters are not deranged too much, like the oxygen does not drop too much, but or the heart rate does not increase too much. But we see that there is the fatigue level is much higher. Hello.
Hi, ma'am. Can you hear me, ma'am?
Dr. Ankita, can you hear me?
Hello.
Yes, ma'am. Now it's visible, ma'am.
Yeah. So the indications are basically activities or symptoms that are disproportionate to the kind of activity we do or the patient does. So if he's able to walk for only, say, 50 steps and he gets breathlessness, which is out of proportion, the parameters may not be deranged too much, the heart rate may not increase too much, but still the person has symptoms. He has breathlessness, or he has leg fatigue, or he has pain in the legs or feet, or chest tightness. So at that time, that is a time when ideally pulmonary rehab would be most useful. However, if not at that time, if we see that have started limiting their leisure activities or social activities due to their symptoms, and slowly they are cutting off their daily activities, that is the time also one can enter rehab. Loss of independence while doing activities is another, so it means the same thing here. And leg fatigue, especially if leg fatigue is limiting the exercises, you all should refer the patients for pulmonary rehab. Now, if there is an active exacerbation or there is a severe respiratory illness because of infective or otherwise, and at that time, if the patient is hospitalized, that also could be one of the times when you can refer the patient for rehab. But at that time, we should keep in mind that once the inflammatory markers, or we see that there is beginning of beginning of improvement, that will be the time patient can be best engaged by a physiotherapist. Because sometimes we may end up doing extra, which may not work with these patients. So when there is an acute exacerbation in hospital, go slow, calculated, and then after about a week of discharge or once the parameters are better, we can engage them in proper structured rehab. Now, the components of rehab are not just exercise, but patient education, nutrition, energy conservation. So in the given figure, we have mentioned three different types of exercises, that is aerobic, respiratory muscle training, and strength and endurance training of the peripheral muscles. Along with that, nutrition and patient education are main important factors. However, along with the amount of exercise, energy conservation is another important topic that physiotherapists would usually cover during rehab. So, the topics of patient education are making them aware about the disease process and see if they are coping up well with it. Help them to participate in the activities, day-to-day activities, work and all. If needed, give modification for the same. Prevention of exacerbations, using of oxygen therapy, titration of oxygen, and adherence to use the therapy is very important. Many times, even if like we often see in our OPDs that especially in patients with ILD, there is a stigma associated with use of oxygen. So many times, even if the pulmonologist has prescribed oxygen supplementation during activity, patients are reluctant to use it. And that's where during our sessions we show them that, oh, see, your saturation drops, this is how you adjust the oxygen, titrate it, and accordingly use it. So if you use oxygen, it will help you. So those kind of things. And patients spend more time with a physiotherapist because they meet us maybe thrice in a week sometimes. So they come and tell us their day-to-day difficulties, their day-to-day issues, and that's where we can help them to overcome it. Sometimes in discussion with a pulmonologist, sometimes we pick up red flags and tell our pulmonologist that, oh, see, this patient has this particular issue. Many times other things like arrhythmia and those things are also picked up during rehab. So we make them aware about what they should observe during an activity, what they should do exactly. So energy conservation techniques and methods also are something. See, these patients have a lot of fatigue or breathlessness during activity. And all the time when either you refer the person for rehab or once we counsel them, the family is behind them to just keep doing exercise or activities to be better. But sometimes it's important to realize that they cannot do these particular activities, and that is where energy conservation techniques play a very important role. We explain to them that you can break the activity into multiple parts, do important activities before, how they can reduce the work of breathing during each and every activity that they have issue with. So such things are explained in this. Ensuring adherence to medicines, oxygen therapy, BiPAP, or other modes of non-invasive ventilation, or exercise. So ensuring adherence to all these things are important. And when we meet them more often, we talk to them about these things as well. Of course, caregiver education plays a very important role because they are the ones who usually restrict or let them do too much or expect too much from the patient. And when a patient is too breathless, it's very difficult to feel unless you get into their shoes. You cannot feel what is exactly happening with the patient. So making the caregiver aware about their situation and letting them do a certain level of activity or not let them do is what we guide them. Overcome kinesiophobia. Yes, sometimes, especially when there are patients who have out of proportion dyspnea or out of proportion symptoms as compared to the activity, these are the patients who usually get very scared to get into any kind of exercise or any activity. So they stop going out of the house, or they stop going to the market, or maybe even for a stroll in their society. Sometimes they get too breathless to go there. So we need to give them a confidence that, okay, you can do it, but these are the measures that you need to take while doing it. It's all about activities of daily living. Rehab is all about that, helping people to get into those activities, optimize independence as much as we can is our job. So every time a patient comes to us, we assess and understand what are their activities of daily living, energy mechanics of or energy economics of a particular activity is assessed. Need. So some people, need to climb maybe four steps in a day, whereas some people need not climb stairs at all. Some people need to go to the second floor. They do not have an elevator. So if they have to go out of the house, they need to use it. Sometimes washrooms may not be easily accessible within the room of the patient, so it may be at a distance. It may be maybe they have to walk 10 steps. Sometimes they have to walk 10 meters to reach the washroom. So these things are considered, understood, and accordingly a plan is made to empower them to be able to do those things, those activities. If modifications are required in the activities, we help them to do that. So for example, most of the patients with chronic respiratory disease, with who start having difficulty in doing their daily activities, first activity they would have breathlessness is the bathing. So bathing is the most energy consuming activity out of the self-care. So when many times when they come, they may not say. So when we ask them, oh, which activity have you stopped? They would say, I have stopped head bath because I get very tired. So I used to wash my hair maybe twice in a week. Now I do not do it for maybe 2 weeks at a stretch. So some people come and say, oh, we have a bath only maybe twice or thrice in a week because we get exhausted. So at that time, we give them simple techniques like, oh, you use a body scrubber with a handle so that you can reach your back easily, reach your feet easily. And that's where, bending and rubbing and all those activities can be avoided. Sometimes we tell them you can have a ventilation. If you are just feeling claustrophobic, just have a maybe small fan in the bathroom, or exhaust usually people have. So those kind of simple things, using a handheld shower instead of taking a bucket and a tumbler, or overhead shower is also uncomfortable sometimes. Using oxygen during their day-to-day activities is again something that during bathing is something that we often tell our patients, because most of the activities they're able to do fine. but they need they desaturate after having bath. So that is the time, we tell them, oh, you observe your saturation level and accordingly start using it like that. Then sometimes we need to provide them with assistive devices such as walker or a stake, or sometimes a walker with a wheel, so that they do not have. So when you use a walker, the upper limbs are completely supported, and that's where the accessory muscles of respiration start working, and they assist in breathing. So walking with a walker consumes less energy as compared to walking without a walker for respiratory patients. So giving them a walker if needed. Sometimes we sorry, we give them walkers with wheels so that they don't have to lift up and put the walker in front. They can just roll it ahead. But we have to be careful before prescribing this, because these are the patients who are at a very high risk of fall, and we need to assess their balance before we give them all these things. So basically, when you send a patient to a physiotherapist, we are supposed to do all these assessments and give modifications accordingly. So everything, including self-care to leisure activities, is what we have to help them with. So managing breathlessness. Primarily, breathlessness is while doing some kind of activity, maybe or maybe at rest. So if there is breathlessness at rest, simple postures like forward leaning with upper limb support, forward bend. So these are certain postures that help them to relieve breathlessness. So we teach them these things. However, most of the time when the person is referred for rehab, they have breathlessness while doing activity. So, so while doing activities, so there are certain breathing techniques that we teach them. We will be practicing, all of us will practice those breathing techniques at the end of the session for you to feel how we do it. So these techniques are actually taught at rest. However, use of it is going to be only during the activity. So initially you wire your brain to breathe correctly, and then utilize these exercise for doing a particular activity like walking or stair climbing or using the washroom or going to the market or whatever. Now, using a handheld fan while while at rest or activities, or maybe just a slow flow of wind is helpful for patients with who have air hunger. And there are certain relaxation techniques taught to patients when we see a component of anxiety associated with activities. So breathlessness, basically, we manage with these things. Apart from medications, what a pulmonologist gives. I've already shown you dyspnea relieving postures. Now, what we tell them? What do we tell the patients? We tell them to be active. We ask them to focus on the activity. We focus on it as activity, not as an exercise, because exercise is something where you need to do particularly beyond a certain limit. Only then you can call it as exercise, whereas activity would be maybe small frequent bouts of maybe something as simple as walking 25 steps in the house. So that would be equal to an activity. It would be like a stop, start kind of thing. Now, we tell the relatives to help only when needed, assist them in activities, but don't do it on their behalf. Use balancing and energy conservation to plan activities, or plan your day, plan your activity at a time. So for example, many people say that after having meals, after having maybe a lunch meal, like a heavy meal, they feel breathless. So what do we tell them? Usually we ask them to come to the dining table maybe 10 minutes earlier, sit there, relax, maybe practice a little bit of breathing, or maybe practice some simple movements get your breath under control, and then start eating. Many times when they eat, when they are eating, if it is especially when they need to chew on something and swallow, you can either chew or you can either swallow or breathe at a time. So when they try to do it together, especially with faster respiratory rate, they end up having cough, or they start feeling breathless because they hold their breath at that time. So at that time, pacing of breathing is important. So we teach them how to manage breathing along with their meals. Also, we tell them about consistency of the meals they have to eat. Um, if chewing food is a problem, then we have to kind of give them certain ideas of what they can do, like have small bites, or maybe have a softer food, later. Keep softer food for later, and have what is difficult to chew first, because you are full with energy at that time. So those kind of things, depending on the need, is done. Of course, I've already spoken about assistive devices, and most important is to encourage ambulation. Ambulation may be within the room, around the bed, just getting up and going to the bathroom, or going out of the house, in the corridor, wherever, whatever. Mobility, movement is important. Lifting yourself up from where you are and going, taking a stroll and coming back is important, because walking is most functional activity of human activities. So if they continue doing at least few steps every hour, that will continue their mobility to go up to the washroom. And that is the activity that is directly related to dignity for most of the patients. They do not want to be dependent for toilet activities on anybody. So these kind of small things are done for patients, and we explain. So all these things are explained to the patient and the caregivers, and sometimes they have nurses, so we tell them, oh, not to restrict them too much and say, oh, let me do it for you. Don't do that. So that's what we keep telling them. Muscle it out. So muscle is the only tissue in body which has to work more to maintain its strength and its ability to do a certain thing. So if we are not able to improve, especially in palliative care patients, sometimes we are not able to improve the strength of the muscle or endurance of the muscle. But in these patients, at least maintaining what is available is important. So we teach them exercises with which at least maintenance is done. If there is a scope of improvement, we work on that. Instead of giving individual muscle exercise or individual joint exercise, we prefer doing the activity as a whole, as a function. So suppose if I want to improve strength of the lower limb or the legs, so I would rather give them an activity of standing up from the chair, sitting down, or maybe going down the step or coming up, instead of giving individual hip flexion, knee extension, those kind of exercises. Because we should remember that in these kind of patients subset that we are seeing, energy is utmost important. So it's very easy for a physiotherapist to give a list of 10 exercises. But I think if we do that, adherence to exercise declines. So we give less number of exercises with which we can get the best results. So we try to keep it as simple as possible, and we tell them that they don't have to stretch it too much. They can pace it out. They can comfortably do it throughout the day. It's important to do small, frequent bouts of activities, like having small, frequent bouts of meals. Now, mode of delivery of pulmonary rehab. Now, basically, there are mainly two things we need to consider: whether we want a supervised session for the patient or we want an unsupervised session for the patient. Now, if there are any risk factors associated with participation in exercise, like pulmonary artery hypertension, loss of balance, any evidence of loss of balance, any evidence of recent cardiac issue, uncontrolled diabetes, uncontrolled blood pressure, and any uncontrolled parameter are relatively, high risk patients. So for them, having a supervised exercise program is a must. Patients who are at low risk or who have undergone a supervised cardiopulmonary rehab, for them, unsupervised exercises are fine. Usually, whenever we prescribe unsupervised exercise as first thing, usually there is a little bit of undertraining, so do not expect too much when we have a complete home program for these patients. If it is totally unsupervised, there can be multiple reasons why we would want to do it. There is distance from the center, there is dependency on somebody to travel to the center, there may be a lack of willingness to come and see or do the exercises with physiotherapists. There can be multiple. So whatever factor leads to an unsupervised program, usually there is a little bit of undertraining because it is, again, high risk. The exercises could be structured or unstructured. When we have a structured exercise plan, we have a definitive goal in head. But when we have an unstructured plan, it is usually just to maintain the amount of activity patient has. So there is no fixed dose of exercise given to the patient. Exercise dose, like dose of medicines, we have 4 heads to it. So there is frequency of exercise, there is intensity of exercise, there is time of exercise, and there is type of exercise, time or duration. So that is how an exercise prescription is done. So if it is done in a particular way, it goes and falls into a structured plan. Unstructured is usually a kind of maintenance dose as per tolerance of the patient. Now, it could be center-based rehab or home rehab, hybrid rehab, which could mean that once a week person comes to the center and rest of the days he does unsupervised by himself. Center-based is completely supervised program. Home-based is completely unsupervised program. Hybrid would be a combination of both. And tele-rehab is, thanks to COVID, we have accepted this very well, and we are doing a lot of tele-rehab. So tele-rehab is something on a video call, preferably on a video call. If not video, then audio call also sometimes helps to at least make sure that the patient does some kind of activity. Now, role of the physiotherapist here, especially in a palliative care center, palliative care patient, is that to teach them how to prioritize the movement, not to do too much, avoid boom and bust of the energy, plan activities in advance, help them to understand their day, week, and sometimes a particular event of activity, help them to plan that. Place their activities such that the energy consumed is utilized properly according to the available energy level. Problem solving. So here, by problem solving, I mean that many times in front of us, patients are fine, but when they go home and try to get into any kind of activity, they may have some difficulty. They may not be able to do certain things that well. So at that time, helping them to get into those proper, forms by maybe modifications is what we do. That is problem solving. And permission. So many times there is a fear of getting into a particular activity where they can do it. Like, for example, if the person is maybe able to do a 6 minutes walk test, because that is a test we do to understand the exercise capacity. He's able to complete the 6-minute walk test well. Saturation, there is a drop in saturation. There is an increase in heart rate, increase in blood pressure. But the drop in saturation is about 88%. That is, the cutoff for them to exercise. Now, if he's doing an activity for 6 minutes, walking for 6 minutes, and his saturation drops to 88, there are high chances that patient would, if he walks for like 15 minutes, naturally his saturation may drop a little more. So in such patients, when we get a series of responses during activity, we know that at certain level, he's fine. If we change some breathing pattern during activity, it changes. So we can remove the fear of that particular activity from their mind and allow them to do it. So permission for doing those kind of activities, or where they are scared but are safe activities, can be done, is done by physiotherapists. So I would request all of you here to sit back, uh, relax with your backs on, with a backrest on your chairs. If possible, switch on your videos, because I would like to see if all of you are able to follow the instructions. And let's do some breathing. Okay. All right. So I want all of you to sit back, relax. Place one of your hand on the stomach, just below the xiphisternum. Keep your shoulders relaxed. Slowly breathe in through the nose and breathe out through the nose. Just observe your breathing pattern. I don't have to tell you physiology of breathing. All of you are pulmonologists. You would know that better than me. But I want you to feel the movement of diaphragm as you breathe. I can see one or two shoulders, like stiff shoulders, elevated shoulders while you're doing it. So here the purpose of asking you to lean against the backrest is just to relax your spine so that you can focus on your breathing pattern. Just feel the movement for, say, about a minute. Observe the volume of breath that you are taking in and breathing out. Okay. Now, I want all of you to inhale up to count of 3 without holding the breath after that. Just exhale up to count of 6. Come on, let's do it. Breathe in. 1, 2, 3. Breathe out. 1, 2, 3, 4, 5, 6. Once again, let's breathe in. Breathe in. Breathe out. 1, 2, 3, 4, 5, 6. Okay, let's breathe in again. 1, 2, 3. Exhale. 1, 2, 3, 4, 5, 6. Breathe in. Breathe out. 1, 2, 3, 4, 5, 6. Now, same thing, I'm going to increase the duration of exhalation. Now, in pulmonary patients, especially ILDs, they may have very shallow breath. So for them, it would be like 1:1 or maybe 2:1 ratio of inhalation to exhalation. Now, the minute we ask them to do a longer exhalation, they kind of calm down. It's like having a sigh of relief. So they kind of calm down. So even if they are ILD patients or any kind of respiratory patient, pursed lip breathing is a technique to go. So now I'm requesting all of you to just breathe in through the nose normally and breathe out through the mouth as if you are trying to blow out for a hot cup of coffee. No, you do not have to puff your cheeks. See, just look at me. Nobody should know that you are doing a breathing exercise. That is how we do pursed lip breathing. Okay, it should calm them down. It is supposed to improve breath control. When we tell them to do it as an exercise, it becomes a little difficult. So if all of you try, you'll know when you see your patients. Just take a breath as if you try to smell maybe some good fragrance. And breathe out slowly through the mouth as long as you can. Breathe in again. Breathe out through the mouth as long as you can. Can you feel the difference if you puff your cheeks and without puffing your cheeks, how comfortable it becomes? Breathe in again. And slowly breathe out through the mouth like you blow out for a hot cup of coffee. Let's do 4 more repetitions because breathing is a continuous subconscious process. We never pay attention on it. Our patients, we breathe about 21,600 times a day. Our patients may be breathing about 30,000 times a day. So we have to kind of help them to control their breath. Come on, let's breathe in. And slowly breathe out through the mouth like you blow out for a hot cup of coffee. Once again. Slowly breathe out. Exhale completely. Excellent. I can see some of you doing very, very well. So, so we teach this particular technique to the patient. The ratio may differ from person to person depending on the diagnosis or the breathing pattern. Sometimes even if they have the same diagnosis, like ILD patients also have some kind of air trapping, or maybe naturally the pattern of breathing changes. So breath retraining is all about getting them more to physiological kind of breathing. We teach them this kind of a technique at rest and then utilize this while doing activity. So when they start walking, we tell them, oh, now while you take 1 step, you breathe in, and while taking another 2 steps, you breathe out. Something similar. So, or keep breathing out, keep blowing out slowly as you walk, as you climb stairs. So this is what helps them. Even if it is, any patient, the minute they start doing controlled breathing, the perception of breathlessness reduces because the respiratory rate automatically comes under control. So this is one kind of exercise. Another simple thing I want all of you to do is just take a normal breath and do humming. Okay, humming like you do Om. but not the whole Om. Om is difficult to do for these patients. You just do at a lower pitch. Hold your head down like that and do it. Stretch it up to 80% of your capacity. You need not do up to where you gasp for breath. Do up to 80%. Naturally, you will see next breath is automatically deeper. So if a normal person can have it, any respiratory disorder person is also going to have similar kind of breathing effect on breathing. I hope all of you are trying. Just take a normal breath. No need of taking any deep breath. Just take a normal breath and do. One more time. Breathe in. One more time. So if you do it, say by yourself also, say for 5 repetitions or so, you will suddenly start feeling a kind of, soothing sensation. It helps to soothe your breathing, your mind also. So basically, people who have a lot of anxiety with respect to, tachypnea, for them, we teach this technique to help them. So these are simple things that even you can tell them to do. Another thing is now let's just do a little bit of exercise. I want all of you to stand up from where you're sitting. Just stand up from your chair. And this all of you can do in your offices as well, for you to improve the leg strength and mobility. So stand up and sit down. I'll time you up for 30 seconds. Please count your own numbers. How many can you do in 30 seconds? I'll start the timer. Your timer starts now. Come on, stand up and sit down on the chair as many times as you can. Nice. You've already crossed 32 seconds. Good. So for you, I asked to do fast as you can, because you are normal and healthy. But for patients, we ask them to do maybe slow or with breath pacing for them. Or maybe we ask them to do, say, 5 before every meals or something like that, because we want to improve the leg strength. Here in this particular exercise, we are working against gravity, improving the strength of the quadricep and the back and gluteus. Also, at the same time, the foot muscles, there is some amount of weight bearing. So patients with osteoporosis need weight bearing exercises and resistance training exercises. So not only them, you can also do these exercises in your office to maintain your leg strength and avoid sedentary more sedentary time. Now, next activity is stand up from your seat and do heel raises. Okay, just go up and down like that on your toes. Up and down on your toes. You can do it for 30 seconds. Dr. Manu Mohan, your form is perfect. You are doing it perfectly. And I must compliment Dr. Pandya. I think we have done 45 seconds. I must compliment Dr. Pandya for his agility. I could see sit to stand also, a lot of repetitions you could do. And heel raises also, you did a lot of repetitions. Very nice. Very nice to see that. So these are simple activities that you can also prescribe in your clinic, in your OPD to these patients. And sometimes, when they come and say that they have a lot of breathlessness, you can make them practice simple humming or simple pursed lip breathing kind of exercise or breath control like we just practiced. Uh, this really helps to improve their confidence in their breathing while doing activities. So I I think yeah, that was it. Do you all want to do more exercise? Do we have time,
Ma'am,
or should we open it for question answers?
we have time till 8 a.m. 8 p.m. Sorry.
Dr.
Yeah,
Farhana,
we maybe we can have
do we have
ma'am, can
time for some more exercise, or shall we open it for question answers? So my take-home message is that pulmonary rehab at any stage, right from diagnosis up to palliative care, up to last moment, is important. There is no time where we cannot do anything. We can teach them simple things which will help to comfort them, keep them independent as much as possible. Our job is not just to push for exercise, but also tell them to pace it with rest periods. Enough rest is important. Pace utilization of oxygen during activities, or ambulatory oxygen, titrating oxygen during activities is the job of a pulmonary rehab physiotherapist. Keeping the patient independent. Optimal independence is utmost importance, and that is where we should do every bit to help them to assess their by assessing and providing them with necessary modifications required. So that is my take-home message. Now, Dr. Farhana, shall we open this for question answers?
Yes, Dr. Ankita, I'm really sorry. I had some technical
You are not
issue.
audible.
Oh, okay. So, are you able to hear me now?
Yeah,
No.
now it's okay.
I think we already have a question. Dr. Farhana, you are not audible.
Yeah, I think there is some issue, ma'am, with my end, maybe some technical issue. But Dr. Pooja says that they can
Can
hear
hear you,
me.
ma'am.
You can
You
hear
can
me. Okay.
also hear you.
Yes, Dr. Ankita, I think everybody can hear me actually.
Yes, yes, madam.
Maybe I can post it in the chat. I don't know if
It is
Dr.
audible.
Ankita
It
has.
is you. We can hear you.
Okay.
Your mic is getting mute and without.
No, no, sir. I was just trying to mute myself in between.
Oh,
Um,
okay, okay.
uh, okay. Sangeet, can you call Dr. Ankita and inform her? Because I think
Sure,
she
sure,
has
ma'am. Just a
some
minute.
audio disturbance. I'm not sure because even before she was not able to hear, right?
Her mic is also off.
Ma'am, can you hear us?
Sangeet, I can hear you. I'm not sure if Dr. Ankita is able to hear you.
Yeah, ma'am, that's
I
issue
can
solved
hear.
now.
I can hear
Yeah.
now. I think there was
Okay.
Yeah.
some problem at my end.
Yes, Dr. Ankita.
Yeah.
So there were a few questions in the chat box previously.
Ah,
Uh, from I think it was from Dr. Sanjay Pandya or Dr. Manomohan. I'm not sure because I had some technical issue and I was logged off because it is raining heavily here at my place. So
okay.
when I logged in, I couldn't see the question. Can you just take up that question?
Yes, I will. So, can you give us from some structured objective outcome based tool for measuring long-term improvement after rehab? Yes. So 6-minute walk test is an objective outcome. It's more structured. It's standardized. Most of the places do 6-minute walk test as per standard guidelines given by American Thoracic Society, and 6-minute walk test is a major objective outcome. Other outcomes would be activity related quality of life questionnaires, but again, they are subjective. So, and by pulmonary rehab, we do not, really see much of improvement in pulmonary function tests or anything of that sort. So, we may not be able to see much improvement in pulmonary function test, but we see that, 6-minute walk test improved. Desaturation is less usually. Amount of energy consumed for a particular activities, those can be calculated in met values, and VO2 max can be calculated. So these are objectives. So VO2 max is like the best objective outcome that we can have for the patient. But so those are all derived outcomes. But 6-minute walk test is more acceptable, reproducible, cheaper, and easily done anywhere. So, that is more accepted objective outcome. Huh. Uh,
Thank you, Dr. Ankita. So, Dr. Sonali says rehabilitation in elderly with loss of muscle mass is challenging. Would you like to comment on that?
yes, I think this is, there is another part to Dr. Pandya's question. I will just go through that and then tell you 1 second. Then I'll answer this question. Sir, I agree that there is a fine. So he's saying that there is a fine line between pulmonary rehabilitation and palliative care. So yes, I agree that there is a fine line, especially when it is and rehab is directed towards improving the functional capacity of the patient. However, at some point of time, especially during end stage diseases, it may not be possible to see much of an improvement. So at that time, it is about maintaining or coming to a particular acceptable level of, symptom limitation. So that is what we do. Yes, coming to the next question about loss of muscle mass in elderly could be a challenge. Yes, and that is why when the person is referred for rehab, we do assess the strength of the muscles, and resistance training is an important part of pulmonary rehab or any other rehab for that matter, because as I said, muscle is the only tissue which can be strengthened by making it work more. So resistance training helps in improving the muscle mass. It helps in improving the balance. It is also a recommended form of exercise in osteoporosis. So, it is like a one-shot thing for all of these problems. So, of course, the dose of resistance training has to be assessed, has to be prescribed according to the assessment of the muscle function. And that's where, usually that is the most important thing in muscle training. Is it clear? Is the answer clear, or you want me to elaborate more on this?
Dr. Sonali is asking about kicking sick patients.
Oh, patients with cachexia. Yes. So, whenever there is any cachexic patient, for them, so for every patient, nutrition goes hand in hand with exercise. We cannot say that, oh, you just keep doing exercises and nutrition is not given attention or not given importance. When we start introducing rehab for these patients, especially if there is cachexia, we first send the patient to the nutritionist, or ideally you should say, like as a primary treating doctor, you should send the patient to a nutritionist first, help them to improve their intake, come to like equal energy level with consumption and intake and consumption, and then work on exercise. So that is how it should be worked on.
Thank you, Dr. Ankita, for adding that. Any more questions? Participants, would
Uh,
you like to unmute and ask?
I think I would add one more point to this, especially when there is a catabolic state. So suppose there are patients of chemotherapy or patients who are, say, emphysematous patients with low body weight and too much weakness and all, and they are with active exacerbation. They are in a catabolic state. So only when we see that there is, that decline has stopped, that is when we should introduce rehab to them. Otherwise, it will be like an over exercise. So that we do not want. Yeah.
Ma'am, there's one question. Dr. Sanjay Pandya is asking, is there any exercise for improving the strength of accessory muscles of respiration?
So in chronic respiratory patients, accessory muscles of respiration are usually overactive. So with exercise, we usually try to reduce the work of breathing of these muscles, because they are small muscles, sternomastoid and upper trapezium and scalenii, and all those are small muscles. They get tired very easily, and that is partially the reason why patients have too much sensation of being breathless or tachypneic. So too tired after doing certain activities. So instead of strengthening them, we usually try to reduce the work that they are doing. We do strengthen them in a particular position, but that is when we see diaphragmatic palsy, where the primary muscle of respiration is not functional properly. At that time, we try to strengthen and improve the strength of these muscles.
Okay, thank you, madam.
Yeah.
There's one more question from Dr. Pooja Baraj. So, do you use handheld respiratory muscle trainers?
So the recommendation of using inspiratory muscle trainer is there. If we see any evidence of weakness of respiratory muscles, in cases like gallbladder, GBS, GB syndrome, or maybe spinal cord injuries, or any viral diaphragmatic palsies. In those cases, inspiratory muscle trainers, or where there is an evidence of weakness, there it should be used. That is the recommendation, latest recommendation by British Thoracic Society 2023 guidelines. So respiratory muscle trainers like spirometer, it is one of the type of respiratory muscle trainer. And again, there are IMTs and all. Let me tell you, these are the most misused device and unnecessarily prescribed device for most of the patients. So if they do not use it with correct technique, and if they are using accessory muscles to do respiratory muscle training, it is actually doing more harm than good. So it should be prescribed with proper thorough assessment, and then we should do it. Yeah.
How much duration and how many times should we recommend patients to do activities?
So it is completely individualized. So, to begin with, especially if you're talking about palliative care patients who are really sick, we tell them to do small frequent bouts of activity, which can be like maybe walking. Some people, maybe walking 10 step is an exercise for them. So 10 step maybe every 30 minutes or every hour, or just get up from your bed and just stroll around your bed and sit. That would be kind of activity. So if the dose of activity or amount of activity is small, it is more frequent. It is supposed to be more frequent. But if it is a wholesome activity, if they're doing it for like good 25-30 minutes at a time, then it could be maybe twice in a day. And if they cross 45 minutes in one go, then it should be once a day. Because it is not practical. If we keep telling them to spend like 20 minutes 4 times in a day, it may not be practical to do it in long term. So as much as the prescription according to guidelines is done, it should be practically applicable and doable in their day-to-day activities, in their day-to-day living. Yeah.
Thank you, Dr. Ankita. Any more questions from the participants' end?
Any more questions? I would be happy to answer, because it's very difficult to put everything in the presentation and talk about it. So if there's more discussion, maybe I can give you more insights. Exercises
So,
for
Dr.
reducing chronic cough. Yeah. So, okay. So depending on the type of cough that they have, if the cough is related to the production and secretions, like COPD patients, teaching them techniques that can improve their airway clearance or to improve their bronchial hygiene. If we teach them that, amount of secretion can be reduced to a bit extent. Of course, changes cannot be, nullified, but frequency of expectoration can be reduced with that. But if there is a dry cough with a dry nagging cough with say, which is associated more with desaturation or with ILD patients, for that we don't really have a technique. In fact, sometimes when we teach them breathing exercises, the cough worsens. So for such patients, we may not even teach breathing exercises. Who especially when they start doing spirometer, there is reflex cough. So for those patients, then we have to approach in different way, not teach them that the traditional methods, and come with our own modification for it. Thank you, Dr. Rajgopal. So I would like to ask you all one question. Acha, wait, there's one more question. Nutrition suffers in patients with compromised lung function. Exercises and balancing nutrition is a challenge. Yes. Yes, Dr. Sonali, yes, that is a challenge. So normally what we do, when we assess the patients for rehab, we take a nutrition history, like screen them for any nutritional deficiency as well. So there are certain questionnaires, then BMI and all those things. We do body composition analysis and understand what is the missing thing here. And if we think if there is a lot of mismatch in the energy consumption and intake, then we first refer the patient to a nutritionist for the same, and then we call them for rehab. However, and then they have a follow-up also. Once the amount of activities increase, we send them back to the nutritionist saying that, oh, we have increased so and so things, please look into it. No, please adjust maybe protein or fat in respiratory patients, so they can increase or decrease the intake accordingly. However, it is not just about the macronutrients and micronutrients in these patients. The consistency of food The bite size of the food is equally important. As I said, sometimes when they have to chew their food, if they have to chew a lot, it causes a lot of breathlessness. And that's why also people don't end up eating much, because they feel breathless after eating. So at that time, it's important. It is a job of the rehab team, including all of them, to understand where is the issue. Is it swallowing? Is it chewing? Or it is breathlessness at that time? So consistency of the food and bite size will come into picture at that time. So many times just changing the texture of the food solves the issue. Sometimes asking them to, so if they have to drink water, for example, asking them to just have it through a straw reduces the issue of breath, reduces their breathlessness. Because many times, and especially in our Indian scenario, most of them have a habit of drinking water like that, like in head extension, and invariably they end up having reflex cough or aspiration. So that's, those certain simple small positions are also important at that time. So nutrition is not just about the nutrients, but also about these things. Balancing is a challenge, yes, but we have to be persistent with it. So may I ask you a question, with your permission, Dr. Farhana?
Yes, sure, go ahead.
So I'll give you a case where there is an obese lady, maybe 100 kgs of weight, interstitial lung disease, end stage interstitial lung disease, oxygen dependent, barely able to do her daily activities, but somehow tries to manage, mostly independent, lives by herself at home, children go for work, there's nobody else. This lady does not move out of the house, maybe up to 6 months. Only when her children take her out of the house, she would be going. So in such cases, whether you would be whether you would refer this patient for rehab, A. If yes, what do you think your physiotherapist, whoever you are referring to, should be like, what should be her approach? Should be the physiotherapist's approach towards the patient? Feel free to unmute and say, please. Because it is your patient, and ultimately he will relate what the therapist does with the patient, right? He will relate it to you.
Maybe
So-
maybe we can have a one visit can be planned at home visit first, and let the assess by the physiotherapist that patient, and let the physiotherapist to decide whether that patient can come once a week or twice a week to the, like an hybrid type of a thing can be planned initially. And if the strength is increasing and giving a result, then the frequency can be increased, and over a period of time again she can be kept at home.
Right. But sir, do you think that there are certain things that a physiotherapist should come back and tell you about this patient? Like from a pulmonologist point of view?
They can tell that whether it is because of obesity she is immobile, or whether it is because of some muscular pulmonary problem. There could be a obesity issue also because of immobility. There may be other factors. So other factors can also be assessed by physiotherapists, like limb muscles and OA or anything else. Anything else could be measured. Whether she is able to stand up on his own or on her own or not. Other factors may be assessed.
Okay. Suppose you do not have an access to a physiotherapist. I think so you are right. And also we have got some answer in the chat box saying that understand her own goals. Yes, it's very important, because if she does not wish to go out of the house and she's happy at home, maybe, the effort will go in vain. But yes, understanding her goal is important. We have to assess, increase insurance, and dietitian to reduce weight. Okay. So reducing weight is a long shot. End stage lung disease, focus already too breathless, already not eating well. Ultimately, there is going to be weight loss. So, here reducing the weight may not be the first thing we think. We might think of knowing whether she's eating the right thing or no, whatever, may not be with the goal of weight loss, or because that is maybe going to happen, not going to happen. But we should ensure that she's getting the right amount of micronutrients and also calcium, micronutrients and protein, so that she further does not gain weight if she's increase eating too many soft foods, and soft foods usually are very high in carb. So those things. Reducing weight could be one of the goal. Recommend her on exercises. One second. Recommend her exercises which she could do at home on her chair. Yes. Swap her diet for healthy food. Yes. Assess strength of knees, hips. Yes. So
it's also good to understand her, like to understand her understanding of her limitations, or like what she can maximize in general to give her a good quality of life. I think quality of life is the most important thing here.
Right. So see, as I said, in this particular case, this lady is living all by herself. So she doesn't have a choice but to be independent, to at least be able to walk up to the washroom, have bath on her own, and eat food by herself, serve food by herself, and all that. So basic things are important here. Now, because she is on long-term oxygen, she may be needing most of these, she may be doing most of these activities with oxygen supplementation. Most likely there will be a long cannula with which she's walking around in the house, and that's why she's able to live by herself. Now, my job here is to assess amount of desaturation this patient has on any kind of activity, walking inside the home, bath, etc. If there is desaturation below 88, my job is to correct it, help her titrate it during that particular activity. Second thing is I should assess for her balance, because loss of balance and fall could lead to more disastrous effect on her health. If she has a fracture or something, because she's an ILD patient, she's on steroid, she may have osteoporosis and she might fall. So my job is to assess her balance as well. So that would be the first thing I would want to do. Second thing, if she is complaining that she's feeling weak, or she's, of course, weight is, yes, there is, the pulmonologist will keep saying all the time. But if she's eating well or no, if she's not, then we need to correct her intake according to her choice. We may have to ask her to take energy dense foods in small quantity, but not so dense so as to gain further weight. So high protein, high fat, low carb diet, something like in that energy dense thing. So this is how usually nutrition is prescribed at that point of time. Then coming to her activities, if she wants to go out of the house or no, that is another thing. Managing exacerbation or acute breathlessness at home. How will she do it? Teaching her correct positions. I should teach her that. During exacerbation, recognize that exacerbation. Check her saturations and heart rate daily to know if the heart rate is more than baseline, or one particular activity is causing unusual fatigue or unusual desaturation. So show her the red flags, tell her the red flags that, oh, this is what you need to remember. If there is anything, please report to your physician. So these are the things, and then making her family aware that, okay, I have taught her these things, you please be observant. And let her do these activities, but she has to take care of all these things. And apart from that, yes, chair exercises, because I don't want to challenge her balance too much. She might not be coming to the center because she lives herself. Kids don't have time, they are out, whatever, most of the time. So for her, safe would be in and around the bed exercises, mobility within the house, bathing, for bathing, if she's getting breathless, giving her, long arm scrubber or something like that, and working on her balance in presence of her caregivers. Teach them balance exercises so that we maintain her balance in a good way. So this is how we should approach, like, broadly. So why am I discussing this particular case? Because I'm discussing this particular case is because this is a geriatric patient, end stage. There could be balance, there could be osteoporosis, there could be multiple things in her case. So here we have to keep in mind not only exercise, but what not to do. Okay, what kind of exercise do we recommend on chair? So we recommend simple mobility exercises for all the joints. Usually it could be a combination of multiple joints, like, push and pull, or throwing a ball on the wall and playing catch with it. So it improves the reaction time also. Sit to stand we just did. We can do cycling on the while sitting. Then you can do simple movements of elbow, shoulder, abduction, flexion. So all those range of motion exercises are the ones we teach. Once they are a little better, we progress to resistance training. We can work on the number of repetitions and number of sets of exercises depending on the saturation and response. Yeah. So that's it from my side. Anything else anybody wants to discuss? Any experience? Any improvements in any patient by rehab? If you want to share with the group.
Participants, you can unmute and speak. We have 5 more minutes, so we can take it up.
Nobody? Any palliative care patient, if anybody has seen and referred?
Pooja?
So I don't have a patient who did better. I have a patient who did pulmonary rehab last year. She did better for a little while, and then, she finished her 12 sessions or 18 sessions. I forget, it was at another center. Now she's back here with me under my care. She's asthma with a fixed obstructive defect, and she's always breathless, and I'm not able to convince her to come do pulmonary rehab again. So she is so convinced that no, whatever I learned last time, I'm doing at home now. It's not working. And I'm dealing with her husband's anxiety. She's a 79-year-old female. Her husband's 85. And do you have any pointers as to how I can get her back to rehab here where I can see her? I'm just trying to tell her it's not supervised. What you're doing is not supervised, but I'm not able to convince.
So you can just call her once for a reassessment.
Okay.
Just check whatever. See, breathing exercises are so simple that they can be forgotten very easily. And many times we see that even if the patients are doing it for years together, they end up doing it in the wrong way at the end of the day. Especially because they have a lot of influence of TV, yoga aunties in the building, here
Yes.
and there, friends, family, whoever. So breathing exercises, especially in an asthmatic, because see, in asthma, there is a lot of airway involved. Like, there is an airway involvement primarily, and there is inflammation. So the way the person breathes in and breathes out should be a linear flow. If it is a turbulent flow, it's going to increase its bronchospasm. So the technique of breathing needs to be assessed once. You convince her to come once to reassess her exercises, reassess, give her corrections if needed. If not, then maybe she needs stepping up from something. Most likely she may not be doing it correctly, or maybe the inhaler technique, you need to check if she's taking correctly. So that is one thing. Another thing is if step up is needed, because the rule of exercise is that you need to challenge. Unless and until you increase the challenge, you are not going to train something. If you want to maintain, it's fine. You do the same level of exercise, you continue it throughout. But improvement should be accompanied by a challenge. Like it should challenge should come before that. Okay, so if you can do that, just call her for one assessment, see how she is, and accordingly, maybe, then you can maybe try to tell her. And there is a recommendation on this. Last year, I had done one course from the BTS itself. So they have a recommendation of repeating pulmonary rehab every year.
Yeah, every year or every 6 months. That's what I'm trying to tell her. But that doesn't work. But I really like that. I'll just call her for an assessment and,
Yes.
correct. That
Yes.
will be helpful. Thank you.
Okay.
Thanks.
Sure. Thank you very much, Dr. Pooja, for sharing it. Because many times convincing the patient to come even for an assessment is not very easy. Okay, there's one more question. We have a lung cancer patient on immunotherapy. Okay. Dr. Sonali says that they have a lung cancer patient on immunotherapy who is doing basic supervised exercises and doing well. Yes. Only thing is with chemotherapy patients, we have to be sure when do we start with them for exercise, because they have a lot of other issues after chemotherapy. There is weakness, change taste, and all of that. So maybe waiting for a week or so for getting into exercise again is a good idea. Yeah. Thank you very much for patient listening.
Thank you so much, Dr. Ankita, for your valuable time. And then I think you have answered many questions because you finished your session at around 7:30 p.m. and right now the time is 8 and the discussion has been ongoing for more than 30 minutes. Thank you so much for being very patient and answering all those questions. And I think the participants, you would have also felt that it was very valuable, adding a lot of knowledge to whatever you knew already. Thank you, Dr. Ankita, for joining us today.
Thank you very much. Thanks.
Over to you, Sangeet.
Thank you, ma'am. And thank you, Dr. Ankita. That was a very wonderful and informative sessions for today. And thank you, Dr. Harshmat, for facilitating the entire sessions. Thank you all for participating actively during the sessions. Thank you. Let's see you in the next sessions. Bye. Good night.
The next is a holiday.
Sorry, sir.
Yes,
Next
Dr.
would be a
Sanjay
holiday.
Pandya. We don't have a session the next week. It's been postponed. And the last session, tuberculosis, will be on July 4, 2024. So we'll all meet on July 4. And we have a homework which has